Morning or good afternoon or good evening to those of you that are joining the first ICHOM webinar of the year. We're going to take a minute just to let those that were in the waiting room join us. As you come on to the platform, if you wouldn't mind introducing yourself in the chat so that we know who we're speaking with today. Your name, your organization, your country would be lovely, so that we can all see and understand where what point of view we're coming from today. So we'll just wait a moment to make sure we've got everybody in, and then we'll get started. Okay, well, thank you so much for joining us. My name is Jennifer Bright. I'm the president and CEO of ICHOM. I'm coming to you from Alexandria, Virginia in the United States, but I'm happy to see in chat that we are already reaching all over the world, including Thailand, South Africa. I see Saudi Arabia, UK, so it's wonderful. It's one of the things I love the most about ICHOM. We are very excited to launch a long list of webinars in our webinar series this year. And we hope to showcase both implementation examples as well as the hard work of a lot of our partner organizations through this webinar series. I'm going to just run through some housekeeping and then briefly introduce our speakers for today and let them have the floor. So first of all, we are recording this webinar. It will be posted after the fact on the ICHOM YouTube channel where you can access it and share it, and we hope that you will. Second, as I asked you, if you are just joining us, please identify yourself, your name, your location in the chat so that we know who our audience is today. And you'll also see on the bottom bar of your screen the Q&A tab, and that is the place for you to add your questions. We will have a designated Q&A segment for today's webinar. But as questions occur to you, please do put them in the Q&A. I have staff, ICHOM staff on the line, and as well as our speakers, and we will endeavor to answer small questions offline as we can throughout the progress. So with that, let's go ahead. I just want to make a few comments before I introduce our speakers. First, the webinar series is part of our effort to really emphasize that ICHOM is a US-based nonprofit, but we have a global profile. We are really pleased that this is a screenshot of some of the things that we accomplished just in 2024 to demonstrate the reach and engagement that we have with patient communities, with organizations like ISPOR, and with many others. And you can see that we are not only doing a lot of public speaking, but we're doing a lot of push communications about the work of ourselves and our partner organizations and institutions all over the world that are implementing ICHOM sets and then bringing that data back for learning. We've had incredible growth in our social media, including LinkedIn and X and Instagram and others, and we're really proud of that. And this effort to host a consistent webinar series throughout the year is part of that growth. Go ahead to the next slide, Anna. And I just want to also acknowledge that we can't do any of what we do without partnership. Partnership looks like a lot of things, big and small. It has to do with investment in our work in both the set development as well as the deployment and implementation projects. It also has to do with, and you can go to the next slide, Anna, it also has to do with building a more visible and connected and consistent alliance with our patient partners. We have a growth trajectory here in this realm, but the way that we work with partners is in co-creation of the sets and the extension of to implementation. And so we work with many of these organizations that you see here, as well as others, to identify who are people with lived experience that can be part of our working groups. How do we engage in dissemination and collaboration? How do we speak at the meetings and the engagements of some of these organizations so they understand what is ICHOM's purpose and what do we bring to the table. All of those things are ways that we partner. And then we also partner with a number of organizations that have distinct and longstanding technical expertise in working elbow to elbow with institutions for implementation and really bringing the data back to learning. And so that's really our focus for today. So you can go to the next slide, Anna. And so today's focus is really talking about implementation of the stroke set and what that learning and that process looked like. And we're really pleased to have two wonderful speakers with us today. Terje Peetso, who's the Chief Medical Innovation Officer for the North Estonia Medical Centre, and our longtime partner, Vesa Komssi, who's Vice President at the Nordic Health Group. So with that, I'd love to welcome both of them to the screen and to share with us their journey and their insights. Thank you.
Excellent. Fantastic to have this opportunity. And we could briefly introduce ourselves. So as Jennifer was mentioning, my name is Vesa Komssi. I'm the Executive Vice President of Nordic Health Group. We are ICHOM implementation partner, supporting different organizations globally in implementing ICHOM sets. In Estonia, we were basically helping in collecting the outcomes, then visualizing the outcomes, and then benchmarking the outcomes between the different hospitals. Terje, would you like to introduce also yourself and the role in the project?
Thank you. Thank you for the introduction, Jennifer and Vesa. Hello, world. I was looking down there when people checked in where you are all from. And I have to say that it's absolutely wonderful what we all learned during COVID, that we can have such meetings online all over the world, people coming together and sharing their thoughts and lessons learned. And I'm happy to do it now here for the stroke patient project that we had in Estonia. I'm from Tallinn, from the North Estonia Medical Centre, and I'm the Chief Medical Innovation Officer. Was member of the stakeholder group who put together this approach, and later as the hospital who was implementing, piloting, and later on implementing. And now I'm happy to share what is that we learned in this project. So maybe, Vesa, you will just put the next slide and I will start.
Yeah, I will. And maybe as an agenda, we thought to first go through a little bit of the background of the pilot, why this pilot was initiated in Estonia in the first place. Then we will go a little bit more deeper into how the outcomes were collected, how they were visualized, then looking also what kind of results were gained, and then some lessons learned and next steps in Estonia in the collection of outcomes. So this is the process, and maybe Terje, you could tell us a little bit about the background.
Yeah. I chose this picture here for illustration of the background. The fact is that we don't have actually a problem with treating the stroke in the acute phase in Estonia. We have all what is needed for getting the patient to the hospital, and in the hospital, the acute phase things to be done. Either it's a thrombolysis or the thrombectomy, or is it another method of treatment. But in principle, perhaps there could be a better response from the citizens to recognize if stroke happens, so that the patients would get faster to the hospital. But it's not such a big problem. But what happens after this acute treatment phase, that was the concern of citizens as well as of our health insurance fund. And with the initiative of the Estonian Health Insurance Fund, which is actually the only insurer, almost only insurer of health in Estonia, but because as you are all over the world, Estonia is actually a very small country. We have only 1.3 million citizens, and we have 6 hospitals who are recognized as stroke centers. So what the Health Insurance Fund noticed that we have a lot of services available, but after the acute phase in the hospital, people going home or going directly to the rehabilitation center, which also may happen, but in particular, if they will go home after the hospital treatment, even after this rehabilitation phase is done for a month, for example, then during the year following the stroke episode, there is a lot of variations in patient journey. And a lot of our patients feel lost in this map. Where, who, how, when, me, or should it be about relatives? How to get to these people, how to engage the family doctor in the right way with right information, how to engage social care, how to put all this patient journey in one map, in one understanding, so that people would get the best possible treatment that is necessary for a better outcome. Of course, it doesn't mean that everybody has to get the same, but that was the beauty of these interventions, that we would develop the system which taking into account the patient needs and learning from the outcomes would be able to choose the best journey for a patient. So we did a lot of preparatory work, actually, learning also from other countries' experience, how to put this pilot phase together with the objectives that would be measurable, reachable, and would really attract our 6 stroke centers to participate in this pilot project. I have to say that the North Estonia Medical Centre, where I come from, is the tertiary level hospital. We provide the highest medical service for our people. So in principle, what happens after the acute phase is of course of interest, but our people don't necessarily feel responsible for what happens with the in the area of general practitioners and with all other services around the patient journey. So to engage our people, our doctors and nurses, our staff in this pilot project, it was a bit of diplomatics, but also we realized quite quickly that it looks like the Health Insurance Fund really wants to make a change. And if we don't contribute and test the change in the pilot phase, then we just have to face with the consequences. So in the end, out of 6 hospitals, 4 qualified for the pilot phase. And if you would show, we have a video actually that describes this preparatory phase and the situation the best. And then I will tell you what interventions we were thinking about during that pilot.
I wonder if I'm muted so that you don't hear it either. Can I hear it now?
My husband had a stroke. It all happened so suddenly and changed everything. I had 1,000 questions on my mind. Why him? Will he recover? How do we go on? They took good care of my husband in the hospital, but when he was sent home, we were left alone with our worries. Nothing was the same anymore, but I didn't know who to ask or where to get help. I feared that I had to stay home with him and no one would help.
In Estonia, about 4,000 people have strokes every year. A stroke is a sudden and severe condition with serious and life-changing consequences for both the patients and their family. Approximately 20% of stroke patients die within a year after the stroke. 50% recover completely or sufficiently to cope with daily life, and 30% remain dependent on external care. In the stroke patient care pathway, a patient meets many parties, from the neurologist and rehabilitation specialists to primary care centres and social workers.
Are you able to see this video now or no? Let's do that again. So I may have accidentally paused the video sharing.
Acute care
Now?
provided immediately after the stroke is effective.
Does it work?
The subsequent care pathway is fragmented
Yes,
and
it appears to
from
be
the
working.
patient's perspective. The process includes many parties, often with poor cooperation or coordination between them, which leaves the patient and their relatives confused and without necessary services. In 2019, the Estonian Health Insurance Fund started a stroke care pathway pilot project. The goal of the project is to improve stroke survivors' quality of life through more people-centered and integrated care. The project has 3 interlinked parts: care pathway development projects, measuring patient-reported outcomes, and a new payment model. The project includes 4 hospitals that in turn have engaged over 50 cooperation partners. The development projects test various innovative solutions on how to ensure the following outcomes. The patient and their relatives are provided with timely information they can understand and be involved as equal partners in decision-making. The parties to the care pathway agree on their roles, meaning who does what, where, and how to facilitate the patient's transfer from one stage of the pathway to another. The patient has a comprehensive care plan that is available to all parties and accompanies the patient along the entire care pathway. The patient and their relatives have a coordinator to turn to for help and who guides them through the different stages. The patient receives services close to their home or at home based on their individual needs and preferences. For the first time in Estonia, patient-reported outcomes will be systematically measured. This helps understand a person's recovery resulting from the care process and what can be done to improve their quality of life. The new bundled payment model means that instead of paying for individual services, a single price is agreed for the entire care pathway. The idea is to stimulate cooperation and coordination between the different service providers to ensure that every stroke patient receives the services they need. The new solutions are being piloted until 2023. If successful, they will be applied nationwide in the future.
Patients and their loved ones shouldn't desperately seek for help and worry so much alone. The Stroke Care Pathway Project seems to be exactly what could help people like us in the future.
Visit the Estonian Health Insurance Fund's website to find out more about the pilot, an integrated care pathway for better quality of life.
All right.
Don't go to that website now. I will tell you first. You can check it later.
And that's actually, Terje, one of the learnings is that it makes sense to put a bit of more effort than you would maybe otherwise do in the communication of the project and the implementation in order to get everyone involved. And I think this video was not sort of built for sort of international purposes, but really for the sort of local implementation purposes. And I think it's a sort of great example of some of the achievements in the implementation.
Vesa, this actually was the international version because in Estonian version, it's in Estonian. But
yeah,
that's
fine.
I think we had one slide before about the innovation. Yeah. So I just want to briefly tell you what is that we did. All 4 hospitals that participated in this project had to come up with their ideas, what needs from their point of view and experience and their cooperation with the other partners outside the hospital, what needs to be done, what could be tested during that period in order to improve the situation. And some of these interventions were similar in all 4 participants, some differed. But what we had all in common, absolutely for sure, was the patient-centered approach, so that we will take into account the needs of the patient. It was about the creation of the coordinating role of the nurse or the coordinator, who does not necessarily have to be with the nursing background, but who will be the single point of contact for the patient or relatives as regards the journey. About this, creating the single care plan, which is available for patient and relatives, but also for all other partners in this journey. The cooperation between, sometimes with the partners that usually we as the hospital are not used to work together, like social care, or with the specific supporting non-governmental organizations that would perfectly fit to some patient journeys, not to all of them. Let's say speech impediment, which is a problem for some, but not for all, and which is organized by an active NGO who would support with impaired groups, patients that usually we don't cooperate with. Of course, this development of home and community services, that involves this approach of integrated care, which is also in baby steps in Estonia. We would like it to be advanced better, but sometimes the systems are quite rigid from both sides. So yeah, that is something that needs to be it needs time and this understanding of the objectives of working this way. Also, what we did some different interventions in hospital. For example, in our hospital, we tested the mobile application for the as a role of the digital coordinator, the app in which the patient can see about their patient journey and the steps and the contact points and all this type of information. We tested the data sharing tool, which is not traditional hospital or healthcare information system, but which was originally for the sales purpose, but which using the approach, which is cyber secure, and using the data protection approach with the identification and authentication, everybody who has an access would provide an access to information of all medical information concerning the patient. We also tried in our hospital the consilium, which will take twice during this 1 year journey, all experts together, taking into account the patient-reported outcomes, taking into account the status, assessing the functional situation of the patient, and all lab results, all what has been written on the 6 months and 12 months after stroke, and finding the optimal way for the journey, which turned out to be extremely popular for patients and relatives, but at the same time equally extremely expensive. And what we also did together with all hospitals and with the Tartu University, the Faculty of Neurology, where we updated the website, because that is something what we also found, that website exists, website was once up to date and fine, but as it didn't have the regular update, it sort of expired. And we definitely wanted to have this website to be up to date and to have perhaps regular news in it so that people can find what is happening in this field. Disease is old, but the treatments are often new. And that video was also posted there for people to know. So that were the interventions that we did.
So this is a sort of important part of understanding that the outcomes measurement was a part of a sort of larger whole, where the sort of these interventions was really the core, but then the measurement of outcomes was in a way one of the interventions, but also a way to measure which of the interventions really brought value and which didn't. So, but let's jump into concretely how were the outcomes collected, how were they visualized. And the sort of in the core of the outcomes collection, we of course used the ICHOM Stroke Set, which if you have been involved in ICHOM implementations, there is a fairly detailed data dictionary, which basically details every single item that you need to collect. So that the first phase was to go through that what of that data is already available, what is missing, what was early recognized that what is missing are the PROMs. So there was a tender for collecting the PROMs collection platform. Then there were some of the clinical outcomes, some of the even the patient demographic information was missing, and those were basically then needed to be either collected in the part of the EMR, or some of those were collected as part of the PROMs collection and included in those questionnaires. But the ICHOM set gives you very comprehensive, detailed view on what do you need to collect, in what intervals, but then you need to figure out how to collect those. As Terje mentioned, there were 4 hospitals where the data was collected, and the patient-reported outcome measure platform was provided by Philips, which is now part of another company. These days, the cost data came from the Estonian Health Insurance Fund. Basically, the claims data was used for the cost purposes. Those were combined in a dashboard which allowed for benchmarking between the hospitals, allowed more detailed analysis of different patient groups, allowed analysis of the development over time, and allowed also for the intervention. And next we will look into in a more detailed manner how did that look like. Typically when collecting the outcomes and also the ICHOM set, it's quite detailed. There's a lot of information, and it's also sort of the typical format is to look at on a per patient level. And that is of course required. In order to have a meaningful impact on the patient's treatment, you need to look at those outcomes on a patient level. However, in order to also use that information for managing the hospital, managing the stroke care in general, what kind of practices or patient journeys or innovations could improve our stroke care, then you need to have an aggregated view on that. So what we did is that we built this kind of a summary dashboard, which combined both outcomes and costs. It also had this deviation analysis, which allowed you to sort of see what's your performance versus the other hospitals in different dimensions of outcomes and costs. But then you could also dig deeper into both outcomes and costs, so that you could dig in the outcome dimensions, different parts of the PROMs, different parts of the clinical outcomes on an indexed manner, but then you could also go into actual raw results. And all of this was presented in so that the maximum or the minimum number of patients in each intersection should be at least 5. And so this would be an anonymized view, so that this would be also able to be looked on the hospital management level. This could be used for research purposes, and this could be also used for the external parties if needed. And here is a sort of an overview that gives you a little bit of picture that once you have collected all of that data, how could it look like, and what could you do about it? And so here we have this is an anonymized version of the actual summary view of the dashboard that we built there. On the left top corner, there's the outcome index. ICHOM set has a lot of KPIs, but it's just a little bit difficult to have a combined view that how good are we doing in general in our outcomes. So we basically built the outcome index that was weighing the PROMs with the weight of about 50%, and then different clinical outcomes were then allocated a percentage. So that's a sort of question of values, that how much do you value different outcomes? There is no right or wrong answer there, but we created a methodology that allowed for creating a summary index there. Then we were sort of lucky in the sense that we were able to have the full cost of the journey from the Estonian Health Insurance Fund, from the acute stroke to the rehabilitation to readmissions and outpatient clinic visits, etc., etc. So full care chain costs. You could then, on the top right corner, you can see how you are able to correlate the outcomes and cost between each other. We will later on see a little bit of the real results and how what did those results imply. And then on the bottom here, you have the deviation analysis that I mentioned earlier, which basically this is if you now the hospital D is selected here, and it shows that on what is your difference in different outcomes dimensions to the average of hospitals. So it's, for example, says that you are hospital D is a lot better in survival and disease control. And even though they have the higher score in the outcome index in general, they have a little bit of room to improve versus other hospitals in the clinician reported health status. And then also on the cost side, you are able to see that, okay, even though they have the lowest cost, they have higher cost in avoidable complications, for example. And on the left, you have a sort of quite a lot of filtering options for selecting specific time periods, patient segments. You are also able to select in the real dashboard, you were able to select case mix adjustment, etc., etc. So once you have this data, there's a lot what you can do with it. Basically, you can look at different innovation projects. Actually, that was one of the filters that you could, those intervention projects that Terje was mentioning earlier, you could select each of those and see their exact outcomes. Those patients that were part of those intervention projects, their outcomes and the full care chain costs. And then you could compare those results with the sort of equivalent patients which weren't part of those intervention projects. And you could immediately see that what was the value of that in terms of the better outcomes or reduced costs. And that is something that is sort of pretty unique, because usually you need to do a very big study and a research in order to get those results. But once you have this in place, you can do over time, you could do several different interventions, several different new ways of patient pathways or treatment options and see the results in this kind of a dashboard. This is, of course, just a summary view. You have then the more detailed views to dig into the actual results and seeing what is it exactly that is happening with the PROMs or with the clinical outcomes, or if I'm taking this specific patient group that has gone through the thrombectomy between age 60 and 70, and what's the outcomes of those in these different intervention groups, you can do that. So that gives you a little bit of picture what's also possible in general once you sort of really take into use the outcomes that you have put so much hard work in getting. And that's usually that is a little bit lacking, that you collect the outcomes, but they are too often just laying somewhere in the database and not used enough. But that's a little bit of the sort of process, how we collected those outcomes. How did it look like in the end? And then we could jump into the results. And And it was quite interesting to see that here we have as a y-axis, we have the outcome index that I showed you just earlier, and then we have the full care chain costs. And these are case mix adjusted results. And we see that the regional hospitals and central hospitals have quite a different profile. They had a very different cost. That is mainly related with that central hospitals didn't offer thrombectomy, which is more costly and basically has an impact on the patient outcomes. But even if you are comparing the both central hospitals A and B between each other, there's a quite big difference that B has significantly higher costs and lower outcomes than the hospital A. Is there something that the hospital A is doing differently? And the difference is smaller between the C and D. That there could be a little bit more uniform patient pathways and the treatment practices in those hospitals, but you still see that the outcomes are better and the cost is slightly bit lower in the hospital C than in the D. And many of those reasons why hospitals had better outcomes than the other ones was usually related with better patient-reported outcomes, fewer strokes, for example. The lower costs were typically related with lower acute care costs and lower rehabilitation costs. And so when we did had a first round of benchmarking with the hospitals and going through these results, but that's probably one of the lessons learned, that it's a big effort of collecting this data, but that's just the start of it. So the vision and the sort of effort should be just at least as much into making sure that the collected outcomes are put into use, both at the hospital management level and then, of course, on the clinical practice level, and not to leave it to lie somewhere. And that's probably somewhere where also in this case we could have gone longer, but that's we can come back to that in the lessons learned. A few more points about results is that we were able to see a quite significantly better mortality rate in this intervention group, and also one of the targets of the whole pilot was to ensure the better use of rehabilitation in general, and there we saw quite a significant increase in the intervention group throughout this pilot. This goes really fast, and I think there would be a lot of more details that we could cover. But in the interest of time, let's go to the lessons learned, Terje, so that we will have let's go through those quite quickly so that we will have time for questions before we need to wrap up.
Yes, I agree. That's very important because we have very limited time. But now we come to the most important point. First of all, what I want to say, people don't make probably difference. What is the central hospital and what is the regional hospital? Because that's always very local understanding. Regional hospitals are the university hospital and our hospital, which are covering basically half of Estonia. South, university, north, our hospital, and central are the local ones, because the terminology sometimes is very difficult to understand. Secondly, what I want to say, we only applied 2 interventions on the same patient. They all got the intervention with the existence of the nurse coordinator, and they all, and then they got 1 intervention. For example, the group that only received this consilium service, or the group that was receiving the speech impediment intervention. So that is how we were able to compare the intervention group and the control group, because otherwise it would be a mixture of everything and we would not be able to attribute the result to anything. So what did that we learned? The importance of sharing data. And access to this information is limited because not all professionals have access to our health information system, which is nationwide. And what we did with this, why I said that we used one sales tool, because the sales tool, what we liked about this was that whoever in this journey did something with the patient, marked it in their database. So others would immediately see that there was a visit of a social worker, because in our health information system, that will not be reflected. It's the composition of the epicris, it's lab results, it's the all these type of summaries of patient discharge letters, for example. But these type of daily interventions, we don't record anywhere, which would be accessible for everybody. So that we learn would be important. This type of data sharing, how we could achieve it, we haven't. We learned that it's good, but we don't know how to achieve it now. All participating hospitals learned that the coordinating nurse is very important to help patients to orientate in this journey. The funding, if the pilot ends, it's all good. Lessons learned, we can publish, we can go to ICHOM conference and make a presentation. But what happens in real life? So how to ensure the continuation of good lessons learned? That is very important. Thanks to our health insurance fund, the nurse coordinator role was added to the list of services, and that now is in all our stroke hospitals available. And we also, based on the lessons learned, adopted the patient standardized pathway, which is in the next slide. And I will not go into details there. If you would change it, Vesa, we go to the next one, because it only describes the important elements in brief here, but they all include the list of interventions which may be useful based on the needs and based on the assessment of the patient situation. So that gives this variability and personalized approach. And I would like to come to my final slide now, which is about what are we doing with all this knowledge. Very briefly to say that the value-based healthcare is not a new term in our understanding. If you would change the slide, Vesa. Yeah, we are, however, not taking it separately as an island itself, because using the PROMs brings us an opportunity to apply also the personalized medicine approach, which is equally called patient-centric approach. But all this knowledge needs education and training. And the health literacy is not only the problem of the citizens. Also, we haven't even measured it in Estonia. So we don't know how much impact on these outcomes has the level of health literacy of people. But learned from the world, we can say, yes, it does. It does. And we need this type of education and training for citizens and for healthcare professionals. We have extended the understanding of this type of journey to other areas for cancer patients and for our endoprosthesis patients with the joint replacement. And we are working also together with the Health Insurance Fund to find the format for or platform of applying the patient-reported outcome measures collection. Because in particular with patients with multimorbidity, this information about the patient quality of life is not only relevant for this doctor treating the stroke, for example, but the GPs would have a complete overview of people with also other diseases on how is it working, how these medications or the surgery or whatever it is would have an impact. And I think that is very important lesson that we learned, that this is a very valuable tool. That's all from my side. Actually, no, it's not. I just wanted to add that we have not yet found this bundle payment. We have not started the bundle payment implementation, because that turned out to be more complicated than we initially thought.
Yeah, so the bundle payment was simulated actually on that dashboard of the cost dashboard, but that wasn't implemented in the sort of actual payments. I think that was a question earlier in the chat, and there's a lot of excellent questions in the chat. I wonder from the ICHOM side, we could now move on to the Q&A part of this.
Hello. Can you hear me okay, Vesa?
Yeah, we can hear you well.
Perfect. Awesome. So we have a lot of questions, and I'm not exactly certain who I'm going to be sending these to, so I will be sending them both of you, unless I absolutely know who's going to answer it. But I wanted to start with what several people have indicated to be a really high priority question, which is, how was the outcome index designed and agreed upon among all the participants in the project, and which party was defined to be responsible for collecting and sharing the outcomes data?
Well, I can say from my side, Vesa, you probably can add, but I can say that we had a steering group for the pilot composed of the people from all 6 hospitals, from the Health Insurance Fund, from the Ministry of Health, and patient groups. And we all agreed what is this measurement that we have to apply. And it was a composition of different things that we were looking at in order to measure the results. PROMs was only one of these.
And how it was calculated, so the sort of simple part is the sort of setting the weights for specific outcomes categories. So for example, as I mentioned, setting the weight of 50% for the PROMs, and then clinical outcomes, sort of different clinical outcomes categories were set weights. And how those weights were set was a group of clinicians from each hospital that were part of the sort of the implementation, which in the joint workshops we basically just decided those, and that's something that can be then later on adjusted if the priorities change. So that's the sort of easy part. Then it's a little bit more mathematical, that how do you calculate the sort of index for each of those dimensions or outcome segments. Basically, you need to look at the total variance of the results. So and then divide the variance or the sort of have the average for the set. For example, if you would have an average of 3 for specific PROMs question, and then you would have the variance of 1, so that you would typically the distribution of the results would be between 2 and 4, where the sort of height of the results was around 3. Then you would set that as 100, and then you would be sort of calculating how much is that differing from the average. So basically, is it 100 or 120, etc. So we actually have a sort of the methodology described in another presentation, but it's not rocket science, but you can sort of just mathematically calculate the variances between each KPI and then calculate the sum of those based on those weights set in the beginning.
On that topic of variance, can you speak to, or did you take hospital price variation into consideration when making those calculations? And if so, how did you go about making those comparisons?
In Estonia, the prices for the hospitals are the same, so the unit prices are the same, so there's no differences. If you would be comparing sort of in the system where you would have different prices between different hospitals, then it's a little bit what you are looking after. So if you are looking the sort of care chain optimization, then it probably could make sense that you would use the same prices. But then if you also want to take into account the actual cost efficiency of each hospital, then you may want to use the prices that they are using in general or the actual cost. But probably in the benchmarking purposes, it may be the easiest that you would use the same prices for each participant in this kind of exercise. And the cost is anyway, it's a tricky part that it's quite rare that you would have very accurate sort of time-driven activity-based costing system in the hospital. But usually you have some sort of crude measures for allocating the cost per visit, per operation, maybe DRG-based or claims-based costing. And in our experience, this kind of crude measures are sufficient in many cases. It's the main point of calculating the cost is to sort of show the magnitude differences between different care pathways or different treatment alternatives, and not to go into detail into sort of analyzing the productivity differences between different hospitals.
Awesome. I now have a question that is a little bit more about the background or structure of the committee in which you organized. How did you decide who would be at the committee to make a decision about relative weights and indicators? And a little background to this question adds that it's about how does a system gain legitimacy and currency? And how does something like this become accepted and used, trusted among government or other relevant entities?
Maybe Terje, you can tell about the overall structure of
I think, well, if you have 1.3 million people, then basically you are all relatives, or at least we are all coming from the same university. That's for sure, because we have only one university in Estonia that teaches medical doctors. So this type of medical approach is quite easy to understand. We have one society of neurologists, and they all share their views and understanding. We have 6 hospitals treating stroke. So to bring all these people around the table was not so difficult at all. It was very important that from the beginning we engaged the patient group, and we had a health insurance fund. We had the Minister of Social Affairs, but Minister of Social Affairs is the one to which the agency is the health insurance fund. So they were involved in this anyway. So I think the need for improving the way we see the patient pathway was clear for all the stakeholders. They all understood that there is something that needs to be done in order to use all our resources better. I would not say necessarily that to save money, because I absolutely don't like this saying myself, because in healthcare you can't save money. You can use the resource better, because it is not only money we are talking about. Of course, the people are also money in the end, if it's healthcare professionals, but to use their knowledge and experience in the best optimal way for people who need it and who would benefit from this, and to involve in the necessary steps the right people at the right time for right patients. I think that is this that describes the best, the optimal use of resource. And that understanding was clear. So everybody supported this. How to get to this implementation and agreement on the milestones and the measurement methods, that of course needed a discussion around the table, and the knowledgeable people who would advise whether it makes a difference or not. If you will put the equal weight to all of these elements, or some of them are more important because they contain more information. I think it's in the end of the day, always with these pilot projects, that's the question of negotiation and arguments. And we were quite friendly people around the table. Nobody was really aggressive, protecting their corner. No, we listened carefully what the others had to say.
So I guess there's key is to have all the stakeholders involved, and have the sort of clinical sort of expertise there, and not just the management. But then one of the key drivers here is that what is the purpose of doing this, and the purpose is not so much so to directly tie this into the payments or, for example, the outcomes, but really the purpose was to drive improvement, sort of identify best practices, identify room for improvement, identify sort of common language between the hospitals so that it's easier to share sort of those best practices. And I think that's really the sort of beauty of outcomes measurement, that once you do that, and once you do that in a similar manner using ICHOM standard, which is basically the language, that allows you to share information and your best practices in a way that is really, really difficult unless you have that common language. If you are collecting very differently the outcomes, you are not able to basically compare with anyone. And it's in the sort of world of outcomes measurement, there is no absolute level of what is good and what is less good, because you always need to compare, and you are not able to compare unless you collect the information in a similar manner.
Awesome. And in the spirit of patient-reported outcome measures and involving the patients in this process, how do patients control the data sharing, and when, or better yet, when and how can they share or access what's important to them in terms of their quality of life or the different patient-reported elements from the ICHOM Stroke Set?
Well, they have a right to have and ask for an access to all data concerning them. They do not necessarily can interfere with this data that are collected because of the legal requirements that we as a hospital have for data management. But in principle, all this information which is about them and for them, they have an access to. For example, this treatment plan, they got it on a paper if they wanted. They can check for this on their patient portal, where we have all information about available for every citizen. And all medical professionals have an access to that health information system as well. The problem was that I also highlighted that, for example, social care doesn't have access to that information. So it was like a double information that we had to collect. And the information was not always on time, like online information, but came later. So that had its limitation. And we also learned that with stroke patients, the digital tools are not necessarily the best because of the cognitive impairment. They would prefer paper, or you are talking to a relative, which or you speak to the patient over the phone. So digital tools are good, but not necessarily for patients.
And I think there was another question that was asking that what was the response rate to the PROMs questionnaire, and what were the sort of ways to get those rates up. I think it was among the highest that I have seen. It was around 90% the response rate, which was really, really good. But the sort of secret sauce there was that there was a nurse calling asking for those PROMs. So if we would have just relied on the digital tools, the response rate, especially with this patient group, wouldn't have been as high.
And this might be just a clarification, something Terje was saying about the, it sounded like, I just wanted to clarify, there was redundancy in what was being collected across the social domain and the healthcare domain. Is that what you were saying in terms of they don't have access across areas to that patient data?
Yeah, social care people do not have always an access. Depends on how it is organized. If the social worker is in our hospital, for example, they have access. But if they are independent or work in the municipality, for example, as the social care service, then they don't. So it depends. But in principle, the access to healthcare information system is for healthcare providers and healthcare professionals, and then patients who have access to their own data, or somebody who has also given a permission, like for children or parents who are not capable of doing themselves, they can give you the legal right to look at this information.
Fantastic. I just wanted to clarify that to make sure I was hearing it correctly. In terms of and maybe this was covered on earlier on, but in terms of I know you mentioned you didn't put all your eggs in the basket of the digital solution, but can you speak to or mention what tool it is that you use to collect the PROMs?
I think it was the platform provided by Philips. Vesa,
Yeah, exactly.
Am I correct?
Yeah, it was the external platform called Vital Health, which was used in the project back then, and that's always the sort of question when implementing that. Usually, the provider doesn't have existing platform that can be used. So then the question is that either you are using this kind of international sort of ready existing PROMs collection platform, which has the user identification, it has the sort of ready dashboards for both the clinician and the patient, and it has the sort of ready time intervals when those questionnaires are sent to the patient, so it makes things easier. Of course, they could do cost some, or then you can use some. You probably have your NPS questionnaire, so maybe then using those or coding your own. Some of our clients have been sort of using their own EMR or patient portal and coding the PROMs collection there. But that's a question that is pretty much in all of the implementations, how to collect the PROMs.
Awesome. I do want to kind of answer a ton of, there were a handful of questions about how did you define the time points for when patient and clinical reported data was collected, as well as how did you know which PROMs to collect? You can correct me if I'm wrong, but I think the backbone or the framework for that is the ICHOM Stroke Set. So that data dictionary you spoke about, that technical document does outline exactly what clinical and patient reported data elements should be collected and when.
Exactly.
So what, how, and when to collect them. So for those of you at home watching this and you still have questions about what was collected and why, feel free to explore our website and check out our patient-centered outcome measure library, where we have 46 different sets and counting.
Yeah,
I just wanted to address that.
So basically, you can there find the stroke set, which has both the publication, which illustrates why these outcomes were selected, and then the sort of detailed data dictionary. And there's actually on the ICHOM website, there's our blog that we were writing at the time of this implementation and also afterwards. So there's a lot more details about the PROMs collection. There's a lot more details about this dashboard and also the initiation of the whole implementation. So maybe if ICHOM you are able to share the link to the chat, so that people can find that also.
Awesome.
Sure.
Yeah, we will
Sure.
make sure they get that out there. I think those are really the biggest questions or the best questions to answer right now. Jen, is there anything you'd like to tack on before I hand it over?
No, there's a couple of questions that are more process related, and I would say there was a question about ICHOM employing principles that are similar to other core outcome standards groups like UMRACT and COMET. In fact, Many of our sets are published on Comet, and we are in alignment with these organizations in terms of our principles for development. We follow, and our process is very, I think, egalitarian. It's inclusive in that we bring together working groups that are both clinical and research and lived experience as the experts at the table, really defining what are those domains and the specific measures based in the literature that are psychometrically tested and available. And we have a lot of criteria. If you have more questions about our methodology, I urge you to reach out to us. You can start with Spencer or myself, and we will make sure you get connected with the right people. But we're happy to fill in the gaps about some of our process. And that's why we really emphasize that these are patient-centered outcome measure tools that are being used. And, I'm really appreciative to both Terje and Vesa for talking about the complexity of implementing something like the stroke set, but also, I really valued what you said, Vesa, which is let's remember what the first principle or the first purpose of doing this work. It's first to understand how can we improve patient health? How can we understand what they need and make sure it's right time, right place, right intervention, both clinical and social aspects. And I think we heard that through both of our speakers today. So there are a number of questions that maybe we didn't get to today, but I'm happy to say that we will analyze those and share out any follow-up resources, links, or answers. You are, of course, welcome to contact us, and we can have further dialogue about anything you would like to explore further. And I'm sure that Terje and Vesa would both be open to being connected to you if you have specific questions about their role or their capabilities. This is part of why we're doing these webinars. So before I do some kind of wrap up, Vesa or Terje, any final reflections or thoughts about kind of what comes next in your journey?
If I may start, I would just say
Sure.
that I very much hope that we have one day the platform for collecting PROMs available, because I strongly believe that it is the valuable tool for not a single disease, but it's the universal tool that would help us understand what works, what doesn't work, and bring the patient perspective into it, so that this personalized medicine approach would also be implemented in that sense that you will get what you need. I don't want to say want, because that is not always what you need, but that it would really work. And I also hope that we will have this patient engagement in preparing and their role increased. But for that, of course, we have to create only the knowledge, but also the feeling of responsibility. And that is the huge work ahead. And if somebody wants to ask more, you can always write to me. Send me an email.
Terje, thank you. Vesa?
Maybe my final words is that it's this can if you're doing this for the first time, it may feel difficult, but it would really help to learn from their earlier implementations. So no purpose of reinventing the wheel, but learning from the implementations. If it is the sort of same set, ICHOM set, but the implementations are pretty similar regardless of the set. The challenges are usually the same regardless of the part of the world. We've encountered the similar challenges, whether we've been doing this in Zimbabwe or US or in Estonia. So don't hesitate to reach out if there's any support that is needed in your journey in the sort of outcomes measurement and value-based healthcare.
Thank you both. And I want to say thank you so much for making time both to prepare for this conversation and to have such an engaging conversation. The two things I'm taking away is that this is really about shared learning. And I think your pilot emphasizes that to the hilt, and identifying things that we all face, a common, to your point, Vesa, regardless of where we sit in the world, there are very common challenges in front of us. The fact that, patients are at the center, not just in word, but in deed, that's definitely a theme I take away from today's conversation. And just to, at our conference in Amsterdam, we presented the first Michael E. Porter lectureship to Elizabeth Teisberg, who was his co-author. And one of the things she left with the audience was, it's so important to start simply and simply start. And I think that is a carrying message that drives ICHOM, but also is very inherent in this case example that we've presented today. Start where you are and build and learn and redouble the efforts. And this is what ICHOM hopes to foster over the course of this year through this webinar series and some other things, which I will share with you as we close. This is what ICHOM was built for, is to be a forum for learning, for sharing global change, and for, really driving for standardized approach to how we use patient-centered outcomes to improve care, and all the things that come after you start with that primary purpose. So thank you, Terje and Vesa. And let me just close out today by sharing a few things that are upcoming that we want you to know about, and please do share it with your networks. First is our next webinar will be Thursday, February 20th, to profile some work that's being done in Bangkok, Thailand by Hospital Pattaya, to talk about heart surgery. You can see the timing on there and a QR code for how to register. For those of you that want it, there will be the ability to download a certificate of participation for you attending that webinar. Next, we are also, one of our major initiatives this year is really digging into our ICHOM accreditation program. We will be hosting a LinkedIn Live session about accreditation, talking with both entities that have been through our certification process, as well as kind of what the process looks like. That will be on February 5th. And I will be joined by Faris Saad, who's with Capadev and who is our partner in helping us move this to implementation expeditiously. And then many of you saw in chat, Scott Wallace, who is leading the ICHOM education program, put the link directly to the website to learn more about the ICHOM education program. As part of that program, you can go to the next slide, Anna. That team is hosting a series of transformation roundtables, which I'm really excited to listen in on this. The first one will feature Jake Grunstein, who is a graduate or a prior student of the ICHOM education program. And you can see the dates for those two sessions, which are meant to be time zoned so that they are easily accessible wherever you are in the world. And you can go to our website to learn more about future cohorts for the full ICHOM education certificate as a value-based healthcare professional. This is a leading program that ICHOM has also prioritized as a major initiative for our organization going forward. And then last, for those of you that are interested in traveling to join the community, we will be hosting the ICHOM 2025 conference in Dublin, Ireland this fall. You can see that information as well as a QR code. We have not opened registration quite yet, but that is coming. So register your interest so that you'll get an email and be the first to register. So we'll be publishing our agenda and the speakers. And last year we had a full house, and we hope to do the same. Over 800 folks from all 6 continents, and I believe we had almost 30 or more countries represented. This is truly an international community of practice, and we hope you'll join us there. So with that, thank you so much again to our wonderful speakers. Thank you to the audience, and we look forward to seeing you again throughout this webinar series. Thank you so much, and have a great rest of your day.
Thank you. Bye-bye.
Thank you.
Thank you.